Hi guys, so as Rick says, my name's Phil Jones. I am from Wigan, so if you can't understand me, I do apologise. English is sort of my second language. I've been a paramedic for about 15 years, and for the last couple of years almost, God, it has been nearly 2 years, hasn't it? I've been an innovation consultant working on the point of care testing for Troponin. This presentation will talk about the setup of the project, paramedic training, the quality control, which is a rat pain, and so we'll talk about some of the implementation models as well. So the project had 3 aims right at the start. Can we do it on an ambulance, first and foremost? So spoiler alert, yes we can, but it's not without its problems. We were going to look at the impacts of pre-hospital troponin testing, so a cost-benefit analysis was done by colleagues at Health Innovation Manchester. They did a really good job of that. And then we were going to look at the potential pathways. Now, what we mean by potential pathways is very far down into the future, very low risk. When we go into TMAX, you'll see, can we leave them at home? Low risk, can we send them to SDET? You're very high risk, because at the minute we have a very strict criteria of people that we take straight to the heart centres. Can we do something with those people who weren't having an ST elevation MI or having silent MIs? But that is very far down the line because there's logistics and operational concerns and staffing and funding and whatnot. So pilot implementation, we started off at central ambulance stations. So if anyone works at Manchester Royal Infirmary, you may know that you can throw a stone across the road and hit central ambulance station. We trained around about 20 staff there, and then we got some additional funding and we moved to the outskirts to Duckingfield Station, the Tameside region, and Ashton on ambulance station as well. Just to give you, when we get on to this, we trained 74 staff members. It was purely volunteer. We did incentivise them with an overtime payment because I've always said if you either feed or pay a paramedic, they'll do whatever you want for you. They got taught everything in relation to the test, how to take the test, the TMAX, use of the risk score, and how to feed back. And that picture, just to give you an idea of the sort of setup, is at Duckingfield Ambulance Station. And the picture itself doesn't do it justice because the actual size is probably the size of that screen. And as you can see, there's 7 devices there. There's 20 ambulances at Duckingfield Ambulance Station. So if you can imagine the scale up required to put a device on every ambulance with spares day and night, it's quite a logistic challenge, which is one of the issues we found with this pilot. So talking about staff training, we took 2 approaches. So initially we started off with a face-to-face training session. We used the Siemens VTLI for this pilot, and we got a Siemens product manager in to initially do the training, and we had an ECG tutor coming in just embed more into some more in-depth ECG interpretation. We did that a fair few times, and then as we got more proficient, we found it to be more safe. We also introduced self-directed learning, which we used the Teams channel for. And we did that for a couple of reasons. One, so we could catch some of these staff, because you imagine people working shifts when they're finally off. They don't necessarily want to come here and listen to me waffle about ECGs and troponin testing. So they could access MS Teams, and it had absolutely everything on that channel to teach themselves how to do the tests. And it also allowed us to have a constant method of communication. So there's obviously a chat function on Teams where they can ask questions and they'd be picked up by myself or one of my colleagues. The equipment itself, as I said, we use the Siemens Teleca VTLI. Now that device has since been discontinued, and it isn't because there was any issue with the device. It was purely a business decision. And our pilot was more of a feasibility study. So we've got a representative from Abbott. We could have used the Abbott device. So it didn't, the fact that they've discontinued it, although it's a shame, didn't affect our pilot in any way. So we use the Siemens Teleca VTLI, as Rick said. It gives us a test in 8 minutes. It's lightweight and it's compact. The little fridge you can see behind it is a portable cooler. If any of you got kids and have remote control cars, that have the 2 battery packs in the bottom to charge it, and it should have lasted between 6 and 12 hours. It didn't, but that was a different issue. We had safety lancets because we used capillary testing instead of venous testing, and they were of a wider bore to get as much blood for our sampling. As you can see, we've got a 45 UL per pet. General alcohol wipes on the cartridges, and as it says in there, it needs to be stored between 2 and 8 degrees, which again was another one of our challenges in how do we keep that cold chain on an ambulance. And then the carry case itself was designed by Open House, You can't quite see it, but at the back of it is a vent to just draw as much air in to keep that fridge going. This was our clinical pathway. So, in short, what happened was we didn't change anything to do with how we dispatch ambulances. So in short, we didn't create a chest pain ambulance because we didn't want any differentiations in care. So when a crew would sign on and they were point of care trained, they would inform control. And if they were the next available ambulance to a chest pain, they could be dispatched. When they arrived on scene, the first thing we asked the crew to do was an ECG and a set of observations. And the reason for that is because we didn't want them to do this test on time-critical patients or patients suitable for PCI. Once they'd undertook the test, all the other observations, and they knew they were safe to stand the test, they would undertake a finger prick test. It would go into the Siemens VTLI, takes around 8 minutes. At that point, most of the clinicians would sit and watch a digital clock tick down for 8 minutes. So we tried to push with them, though, it's just crack on and do what other things that you need to be doing, because what we didn't want was these clinicians staying on scene, doing nothing for 8 minutes, wait for the test, and then start doing the things they should be doing, because we didn't want a huge delay on scene. Once they had the results, they would take a screenshot of the TMAC system, which we'll talk about in a second, add it to our EPR, and then that would go off to the hospital, so the hospital could review that breakdown. As I said, we followed our standard protocol, and we added them in, or we added the TMAC risk score as well as the troponin figure into our records. We did test on PCI suitable patients or time critical patients. As I said, we don't want to be sat on scene. One of the things we did push is that acute coronary syndromes obviously raise your troponin level, but there are other conditions out there that will do the same as well. So this is your TMAC breakdown. So for the clinicians in the room, you'll probably recognise the 7 questions at the end. This is, as me as a paramedic, this is what I'm going to be asking patients who have experienced chest pain. And you get a point for it if you've got it, and obviously you get nothing if you don't. So if you've no ECG changes, you get a 0. Work through those questions, and then at the end we put the troponin figure in, and that will give us one of these 4 risk percentages or risk categories. I don't need to read them out for you. One of the things that we did find with the pilot is that we had a change in sort of a response with the very highs or the high risk, so over 95%, in that we would then blue light those patients into hospital and they would be seen faster based on this result. So before we did anything else, we've already seen sort of an improvement in care for the very high risk patients that we're seeing. Hospital handover, so we had Manchester Royal Infirmary and then we had Tameside General who were involved in this pilot. So with the handover, with everything else we present, so your observations, the history, your ECG, we added the TMAC risk percentage, and we will give them the category as well. The idea behind this was that the hospitals then can use that information to stream the patient. So if they are high risk, they need to be in resource. If they're a very low risk, can they be seen in SDEC? So already looking at changing those pathways for the betterment of the patient. Obviously, the ambulance service does have a pathway into same-day emergency care for your SDECs. Not always accepted for various reasons, but the hospital triage team can obviously make those same referrals too. The QC process was the absolute bane of my life for about 16 months. So we had 15 devices spread across 3 sites, as I've said. So once a month, I would collect all 15 devices. We sent them over to Duckingfield because that's where we had the most space. And then, as you can see there, we had 3 levels on the manufacturer's QC and 2 patient samples provided by an EQAS. So that's 75 tests a month. If they all passed first time, which they didn't, a lot of the time, they were kind of like petulant kids after a little bit. So you can imagine the time that would take to go collect all 3 sites, collect all the devices up, run 5 levels of tests, and then get them back so there was no huge delay in testing. And as I get on to the end of this, the barriers, this is almost like a full-time role for someone if you consider upscaling. We did send the results over to point of care MRI. We had a brilliant team led by a biomedical scientist by the name of Jessica. She then provided a report back to us to look at any sort of drifts in the QC. And she also troubleshooted any faults with us as well. Towards the end of the pilot, probably the last ones I did, 8 devices failed. And then I went to Jessica and I was like, what is going on? And it turns out the QC batch had failed, not necessarily the device, so they weren't able to work. It was just we needed to get a fresh batch. So I was kind of worried at the end because more than half failed. So potential point of care. So predominantly we used an ambulance or ambulance clinicians. What we did introduce was a diagnostics care as well. So your ambulances I've mentioned already, they would be allocated in time order. If they had a point of care kit, great, they would do the test. If they didn't, we followed a normal pathway. What we did was with the RIV was me as an advanced paramedic, sign onto a car, I would look at the list of jobs and I would just go chest pain, chest pain, chest pain, chest pain, and I would go and see them all and I would run the test. So they would get an early assessment and they would get a test potentially quicker. As you can see there, there's pros and cons with either model. So the ambulances, we can reach far wider patient group because we're training more staff in the use of it, and it will provide a standardised approach. So we train every paramedic in NWAS, every patient that they're seeing would get the same treatment. The downside to that, large-scale training program will be required because I think we have about 5,000 staff members, large proportion of them are paramedics. As I mentioned before about the setup at Duckingfield Ambulance Station, where there's 20 ambulances, and we had the size of that screen for 7, times that by 3, and that's what you're looking at. Obviously that varies with different ambulance stations, but the logistics and estates requirements are quite an issue. Costs as well, as with everything, the device, plus the cartridges, plus the QC, plus the setup, accounts to quite a lot. And as I said, the QC was the bane of my life, and it would almost be a full-time job for somebody to go around and QC these devices. Probably several people. We have 13 sectors in NWAS. So imagine having 13 sectors to QC. It's not a one-person job, it's a group of people. The RIV, on the other hand, was manned by experienced staff, including advanced practitioners and paramedics. We could utilise an increased opportunities for see and treat, where it says ultra, I mean alternative transport. So we go and see a patient, they're at low risk. Can we use family transport, taxis, urgent care, things like that, rather than an emergency ambulance to try and ease that pressure? We're also targeting chest pain patients to get that really rapid assessment, but equally in doing so, we're creating a disparity in that region because we're not getting to every chest pain patient. You will get more out of it because we'll see more patients in a day than you would in an ambulance because we aren't going to hospital. And because we're using maybe 1 car per sector, that estates and logistics issues isn't such a burden. But as it says, the smaller patient reach because it'd probably be one RIV, sorry, and there is that potential for differentiation. Now, obviously, I'm a paramedic, so I don't work in A&E, so apologies if any of you do, and you can select this all you want. So, benefits for arrival at A&E. So we can do direct referrals to SDEX. So I assume can triage staff or staff in A&E. As I mentioned before about the high-risk patients, we're bringing them in under blue light conditions. So they get that faster initial assessment. Using the risk score, potentially we could use it to benefit if you've heard of the fit to sit, basically it's instead of having every patient on a bed, because research has shown that they appear to be ill or feel more unwell, we put people in chairs who can. So the fit to sit program using the TMAC score, if they're a low or very low, could we use a fit to sit? Well, we place them into the waiting area, we book them in at reception, and then we leave, freeze the ambulances up, and the patient still gets seen. Or we have another initiative called Call Before Convey, where we ring the receiving hospitals, give them the presentation, could even add in the TMAC score, and then we have that discussion about what we do with them. In hospital uses, point of care testing, Rick mentioned the BEST 2 study and the iCare Faster. So iCare Faster initially tested patients at the point of triage because they get a result within a really short time frame. If it was below a certain mark, do they need to be sat in that cubicle? Could they be sat in the waiting area? And as it says, you can use it to make decisions and stream to other areas in the hospital. So the barriers. So maintaining the cold chain was probably our biggest challenge because we're in a Fiat Ducato van, which probably doesn't have aircon because they're rubbish. So trying to maintain that 2 and 8 degrees was really difficult, especially if you can imagine when the after 2 weeks of the year where we get it and it's 27, 28 degrees, it's even too hot for the device itself. And the fridges were failing along with the cool bags that we use as well. So we had quite a lot of wastage. Sample sizes, we had issues around getting a sufficient sample. Now, this wasn't a lot, but it was enough for it to be worth a mention. We chose not to use venous sampling. And the reason we chose not to use it was because of the amount of time that it would take on scene. So we would always do a blood sugar monitor on a patient, chest pain patients. Because we're using capillary testing, we get 2 tests for the price of 1. If we were to introduce venous testing, we would have to test every patient, even your very low risk. We would have to get a line in. We would have to then get the sample off and then run it. And we all know that there's patients out there and their veins dance around or they just blow. So it would result in an extended on-scene time, which it was too much of a consideration for our operations staff to sit on scene, even in Manchester, where you were about 15 minutes from any hospital. The QC process, as I've already talked about, absolute pain in my life, really time consuming, used a lot of resources, used a lot of cartridges. And then finally, retaining paramedic involvement. Now, this isn't specific to us. I think every pilot, you struggle to maintain really good numbers of involvement from staff for a variety of reasons. Particularly when we spoke to staff as to why they dropped out. It was, again, getting sufficient samples, cold chain kept failing. It was an extra piece of kit that they had to get at the start of the shift. So because it wasn't part of our normal setup, it was something additional they had to do. And they just felt that it was too much, so they stopped testing. It isn't all doom and gloom, because I realise how much I've just talked about the barriers. So when we asked about, can we do it on an ambulance? Yes, it can be done, but it's not without its challenges. I did text. So in addition to my bit that we usually, I have a colleague by the name of Rhiannon Williams. She's been our evaluation on this. She's been absolutely brilliant. She usually does a presentation that follows on from this, which covers absolutely everything. So I texted her and just said, can you give me the headlines? So we tested 638 patients over about 16 months. We initially started with a 75% success rate. So that what we're deeming as a success rate is where we've got a troponin figure at the end. That rose to 86 by the end of the trial. Our on-scene times, which is absolutely huge for the ambulance service, how long we're spending on scene, was initially 12 minutes. So we did 638 patients, times that by 12, and that's the amount of time in total potentially covering the scene for. That reduced to 9 minutes, which is really good. Projections apparently show that changing pathways could benefit 30,000 patients, which is obviously huge. And we did speak to patients and staff, and it was positive from both. Patients like the idea that we can test in the hospital, in the ambulance, rather than just going to hospital. They had questions about reliability and what would happen afterwards, like i.e. if we leave a patient at home, how would we follow them up? But on the whole, it was well received. The paramedics liked it because it was an extra piece of decision aid. So when we're trying to refer to a GP for a chest pain, and we do see and treat patients that have had chest pains, usually something that's so far away from cardiac that we can confidently say it's not to do with your heart. But having this piece of kit to go, we've done a trop test, this is the risk score. It's just an extra piece to the puzzle that we can give over to the GPs. Phone has decided to just lock itself. Yeah, so just looking at the last one. So can we create a pathway? We can create a pathway, and the next bit that Rick is currently working on is where we potentially leave the very low risk at home. So we'll go out and test them. If they come back with a 0 to 2% chance of having an MI, can we leave them at home? And that is a large proportion of the patients we take. The data bit that Rhiannon will present on, your very low risk and your low risk were about 2/3 of our patients that we saw. So do those patients even need to go to hospital when we're taking them unnecessarily? So I always finish with this one, as it takes a village, because we all know that doing projects like this, it's not just one person, it's not just Rick, it's not just me. We've worked with Siemens, MFT, Health Innovation Manchester. Daniel's been involved in Innovate UK. So it's not a one-man band, it takes a big team. And that is our POCT village. Thank you very much.